Our next speaker is a fellow of the American Academy of Pediatrics and current co-chair for the neonatal practice section of the American Society for Parenteral and Enteral Nutrition. She is an associate and visiting professor at the University of Cincinnati. And more importantly, she is the medical director of RBMJ Nutrition. Please welcome Dr. Christina Valentine.
Thank you all so much for being here this afternoon. It's a pleasure, and thanks to the organizers for having me. I'm going to talk to you about a topic that's been near and dear to my heart, and that is the importance of DHA in pregnancy. I want to walk you through a little bit about how specific DHA is, because I think folks tend to use the terminology omega-3 very casually, and DHA is a very specific omega-3 fatty acid. In addition, I want to go through the evidence there is from epidemiologic studies as well as randomized blinded trials on why DHA is so important in pregnancy, and then finally leave you with some questions for your own clinical practice on what omega-3 are you actually using and how clinically we could do better to translate this to our patients. I am a neonatologist, and I do find that the information on DHA is really the most impactful for me as a practitioner, and that is preterm birth. This is one of my former 22-weekers. We are keeping these babies alive younger and younger, and if you look at this little baby's face, you can see that the eyes are fused, the ears are fused. It's a huge burden on the family, on the patient's outcomes. We've been talking about long-term outcomes. These babies are set up to have all those problems in their future health, from development, behavior, as well as cardiovascular disease. So if we can impact this with a very, very low risk product like DHA, we can have a high impact on public health. Across the world, preterm birth is 11% of all live births. That's huge. Billions of babies are being born at this age, and multiple countries are experiencing billions of dollars in the US alone on this burden. So let me begin with docosahexaenoic acid, or DHA. This is its chemical structure. I have done basic science as well as bedside trials. This is my third FDA trial on this product's use in pregnancy and lactation. I encourage you, if you just go to my PubMed link with my name, you will be able to download many of these studies as you're watching this lecture today for free, because they are funded by the National Institute of Health. So docosahexaenoic is a very specific omega-3 fatty acid. It has 22 carbons, 6 double bonds, and we can biosynthesize this from the parent omega-3, linolenic acid. However, I'm going to show you a glimpse on why our perinatal patients might have more trouble doing this, and why pure DHA becomes very important in their diet or as a supplement. The only dietary source of docosahexaenoic acid, or DHA, are the fatty marine fish. And I want to bring that out because I come from an area of the United States that many of the women say they eat fish, but it's the tilapia fish. It's a white, anemic fish that has no nutritional value except for some protein, okay? So maybe bodybuilders, it's a good fish. But many of my moms do not eat the salmon, the mackerel. Now here, in many of your countries that are more ocean dwelling, you might have better luck. But for us, we had to come up with a strategy to think about how to get this in our mothers, and you're going to see why in just a few minutes. This was a paper I published a few years ago now that looked at why in perinatology we have trouble synthesizing this. If you go to the right-hand side of this chart, this is alpha-linolenic acid, which is our essential fatty acid. that we can't make as mammals, so we have to get this in our diet. And in our liver, we have desaturase and elongase activity that makes docosahexaenoic acid. However, you have to realize that linolenic acid can be used as a caloric source if the mother is not eating enough calories or protein, and that will never then be a precursor for DHA synthesis. Also, corticosteroids inhibit the first enzyme in that activity, and so what do many of my moms have on board in the clinical setting to avoid preterm birth? Many of them are on corticosteroids or to help with lung maturation. So you're setting these families up for a gap in docosahexaenoic acid. And the reason it's so important is because docosahexaenoic acid is what is active in the membrane. Linolenic acid doesn't have any function in the membrane of our activities, and I'll show you that in another glimpse. Now, another important fatty acid is linoleic acid, or the omega-6 fatty acids, and historically as humans, we had a 1 or 2 to 1 ratio of this so that we could fight infection and do really important things with the prostaglandins on that pathway, but we would attenuate the inflammation with docosahexaenoic acid. In my unit, we did a study to look at the dietary intake of my moms. Our ratio in the United States right now is 50 to 1. Okay, so the balance is way off, a lot more inflammation. So when I talk about supplementation with docosahexaenoic acid, I'm not talking about superhuman doses. I'm just talking about getting that balance back to where we were supposed to be when our brains grew the most by the sea. Now, one other impediment to DHA synthesis is our genetic background. If we have the minor allele for that first rate-limiting enzyme, the delta-6 desaturase, we can eat all we want in DHA, but it won't ever come out in our breast milk. It won't transfer to our fetus, except if you have the right dose. So I'm going to show you a glimpse of that in just a minute. Now, the reason DHA is so important in pregnancy and to attenuate preterm birth is because preterm birth is an expression, an overexpression of normal pregnancy triggers of inflammation that pushes the baby out, if you will. And OB-GYN's in the room. I apologize for the simplistic description of that, but essentially, early preterm birth is that delivery too soon. And so really looking at docosahexaenoic acid in that phospholipid membrane, and I'm sorry, I'm not an artist like some people had great slides this morning. Those look like little sperms. They're not sperms, okay? That is supposed to be the phospholipid membrane. And when you have that lipid raft in that membrane, many series of activities happen to attenuate inflammation. From the left to the right side, you can see decrease in inflammatory eicosanoids, thromboxanes, activating factors, NF-kappa beta activation is attenuated, so you have less inflammatory cytokines. If you look at the fatty acid tissue itself in a human, produces N-acetylethanolamines that then impact the metabolic health of the individual because it has less expression of cytokines from the adipocytes, which is remarkable. And then for pregnancy's sake, we want to make sure that we have enough DHA for that child's retinal development as well as that baby's brain accretion, because we know that that is, when you look at the more recent MRI studies, you can actually see in the brain of a growing fetus where that DHA is being laid down. The hippocampus, the frontal lobe, the motor cortex areas of the brain. And so you can see why mood, affect, and balance can be affected in these children if you have the proper DHA. Now, when you look at the fetus's capabilities and accretion of DHA, what is actually happening? If you look at the placental accretion using cortocentesis, using more sophisticated measures, you can actually see that docosahexaenoic acid is preferentially transferred above any of the other fatty acids. Such that I was explaining to some colleagues earlier today that a lot of folks believe mom's fog brain that she gets in pregnancy is because if she's not eating DHA or taking supplements, the brain will lose DHA to get to the fetus. So we really want to make sure we impact mother's health as well by making sure she has enough DHA. If you look at the fetal capabilities for those desaturase and elongase activities, they are there, but they're not sufficient. So again, like my mothers in Ohio, the fetus really needs a preformed source of docosahexaenoic acid from food or from a good supplement. Why this becomes so important throughout pregnancy is you see this exponential accretion. This is an illustration that shows, if you look at the first trimester, second trimester, and then third trimester, look at how much DHA is accreted. So any of us that take care of preterm babies, and I just published this recently in the Journal of Pediatric Gastronutrition, if you have a preterm baby delivered, you better jack up your mom's DHA so her breast milk has more, so that preterm baby has adequate DHA at intrauterine accretion. And it really influences their inflammatory markers as well as their growth. Very important. So what is the evidence? I'm going to give you a glimpse, and I hope that I'll be able to convince you that in all of our practices, we need to be more specific about DHA, as well as encourage our mothers for food or supplementation sources. It all began with epidemiologic evidence that really showed families that lived in areas where they had a lot of fish intake, and this was a nice picture out of Seattle, Washington in the United States, this beautiful, healthy salmon who actually gets his DHA from eating the algal source. Okay? And that's why wild-caught salmon is the most healthy. And we have to make sure we differentiate not just the tilapia to salmon, but we tell our families wild-caught. Make sure you check for that on the label. Here we're going to walk through some of this. There was a really nice study that showed if you take a chicken and you make sure that chicken feed has DHA in it, the eggs will have more DHA. That is one way you can chemically get more DHA into families that might not eat fish. So vegetarians often have a hard time. Actually, if you look at vegetarian populations, they often have 24% preterm birth. I just showed you the average is 11. So as we look at our families, some vegetarians will let you have some eggs in their diet, or you just have to use supplements. In this study, they randomly assigned moms to get DHA eggs or just the regular eggs where the chickens weren't fed properly, and they increased gestation by 6 days in a good way, from a 31-week average to 32-week average. And people were like, this is a neat association. Let's look at this a little further. One of the groups that you've got to keep your eye on, they've published so much. They initially saw that in the Faroe Islands, that those families that ingested more than 3 fatty fish a week had significantly less preterm birth. And since that time, they've published many more studies. On this slide, you can see the references that omega-3 intake was really associated with the DHA. It had longer gestations, less low birth weight babies, and better pregnancy outcomes. So it really got people thinking that we needed to do trials and actually look at this. In the United States, in our very own Ohio State University, where I have one of my big trials going on, our maternal fetal colleagues were doing a progesterone study. And in that progesterone study, they also had an omega-3 arm. And they retrospectively and observationally looked at the data of this trial. And they found that the mothers who had 3 of these fatty fish a week before 22 weeks gestation, so there started to be a window of opportunity again in that early pregnancy, they had significantly reduced preterm birth. Conversely, if the moms had the lowest quartile of DHA in their red blood cells, they were the highest likely to have a preterm birth. And they looked at all the other confounders that you can imagine, smoking, hypertension, diabetes, and this really stood out in this observation. One of the most powerful cross-sectional examinations that I've seen recently that really touches all of us around the globe was this one. I highly recommend you get this paper. When they looked at preterm birth rates less than 36 weeks, 7 weeks, and they looked at omega-3 intakes across 184 countries, so it's a really nice examination of global DHA and outcomes on preterm birth. They found that preterm birth decreased by 1.5 times for every increase in omega-3 intake of about 380 milligrams per day. So by just having 300 more milligrams, and they found that in that observational cross-sectional examination, the goal dose was about 600 milligrams per day of DHA. So from diet and supplementation, this was extremely impactful on the rate of preterm birth. And you can imagine just one less preterm birth in my unit is $900,000. Not just on the family's sake, but in that immediate hospital period. That's how much of a cost savings this intake could save us all. Okay, what's the reality? Unfortunately, globally, maternal dietary habits are changing, such that we did a study and found, on average, in the US, our moms are only taking in 23 milligrams per day. And the experts say you should take up to 1,000 milligrams. And that last cross-sectional survey said you should at least take 600. 23 milligrams, and these are all comer moms. So I've looked at cross-sectional examination of coast to coast in the United States where they should be eating fish, still low, still extremely low. So there's a problem in our dietary habits that we are addressing in my unit. We now talk to all our moms about their diet in our NICUs because of this opportunity to capture them. So the expert recommendations are very big. 200 milligrams to 1,000 milligrams. Where do you pick? Well, if you look at supplements, they're very diverse. You have to be so careful. When I first did my study, even though my maternal fetal medicine colleagues write textbooks that people across the world use, they were writing for the mother to take prenatal vitamins with omega-3. They were trying to encourage that, but they didn't realize when the moms got a lot of their vitamins, the omega-3 source was linolenic acid. It wasn't DHA. So now we specifically make sure the prenatal vitamin must have DHA. You have to really watch that, because not all omega-3 fish oils will have the minimum requirements for DHA. As a matter of fact, some of the fish oils, if you turn the bottle around, only have about 23 milligrams of DHA. That's not very much for our lactating and pregnant moms to try to get in that 600 to 1,000 milligrams. Also in our studies, what we found is when a mother is pregnant, they have esophageal dysmotility, they have fish burps, they don't want a fish oil capsule, they're vegetarian, they don't want a fish oil taste. And so you can improve tolerability if you find an algal source for that mother to take. And that's what we did in our trial. We finally said to ourselves, we're going to use an algal source of DHA, and none of our moms have problems with those fish burps, and they tolerate it very well. So keep your eye on that, because one thing they don't point out in a lot of studies, I'm going to talk about the blinded randomized trials in just a minute, is that if you use a fish oil in your trial and you don't test maternal blood and find it's improved, or cord blood, how do you know the mom didn't not take all that because she was having troubles with it? So just watch that tolerability. Dose of DHA matters for two reasons. What we found was, if with the algal source of DHA, we were able to get mom's levels up within a week by measuring milk levels and blood levels. In addition, if we used 1,000 milligrams of DHA instead of the 200, we were able to overcome the minor genetic allele. That has never been shown before. If you look on the right-hand side of this chart, if you look across the bottom, it shows you the alleles of that fat S2. We gave 1,000 milligrams, 200 milligrams, 200 milligrams. The minor allele group that got the 1,000 milligrams were the only ones that increased their levels. The 200 milligrams did not increase. So if you have a trial, make sure you look at the fine print. How much DHA was in there? Did it change mom's blood levels? Because if it didn't change her blood levels significantly, it's not that DHA didn't work. They probably weren't taking enough, or they didn't take the capsules. So really watch those studies. Okay, few more slides, and we'll, in lieu of time, just make sure we get to everybody else. When you look at the blinded randomized trials, another criticism we found is that watch the diversity in the groups. If you want a really robust outcome study on DHA, you'll want to make sure there's racial diversity, geographical diversity, as well as make sure the supplement of DHA is a pure source, that it's actually absorbable, that the blood levels change significantly, and that way you can tell if the DHA worked or didn't work. Also, watch their definition of preterm birth. Is it regular preterm birth, less than 37 weeks? If you impact preterm birth, in my opinion, it doesn't necessarily have to be just the early preterm birth. Some folks are just focused on the early preterm birth only, and we all know one baby less at 35 weeks can be huge for our families, not just the early preterm birth babies. Two of the bigger robust trials that have been published in the last few years were these two. And Dr. Carlson is in Kansas. They gave the 600 milligrams per day, which was like the cross-sectional examination, versus a placebo in their pregnancy trial. And what was remarkable, they had a 5-fold reduction in babies born less than 34 weeks. If you look at this chart on the left-hand side and go down to the gestational age percentage, 0.6 versus 4.8 was significantly different. Also, they didn't have a single baby less than 1,500 grams. That's huge for me as a neonatologist, because those babies less than 1,500 grams are the ones that need IVs for nutrition. They need to be intubated half the time for surfactant. So if you can reduce that, that's huge. In addition, if you look at their cord blood changes of red blood cell phospholipid DHA, I want you to be careful about this. Look at this. Those moms' blood levels went up to 7 from 5.9% fatty acids. That's a great level, okay? At the same time, the McCrady's group from Western Australia also had a trial. They didn't power it for outcomes on preterm birth, but they were looking at maternal depression, and indirectly they found a 3-fold reduction in preterm birth. Again, I want to point out, look at their cord blood, red blood cell phospholipid was up to 7. And I bring that out because a more recent trial that they did with a lot more women, where they actually powered the study to look at early preterm birth. They used the same capsules they used in their previous trial, but if you look at the New England Journal of Medicine paper they just published, They did not find an outcome difference on that early preterm birth. However, look at their DHA status. It's about half of what it was in their original trial. So what was it about this multi-site trial that they didn't have the same outcomes? In my opinion, they didn't increase the DHA like they did in their first trial. And that's what you got to look for. Because if you look at their appendix data, in their lowest quartile DHA status had significant increase in preterm birth. Significantly different. So watch those blood cell levels. Finally, one of our more powerful ways to look at this is a meta-analysis. This is 70 randomized trials. Okay, if we had 70 randomized trials about a drug, we would all be using it. Why do we have such a hard time believing that it could possibly be a nutrient to help us, right? 19,000 women in this cohort. This found that increased DHA omega-3 lowered risk of preterm birth by 11%, lowered the risk of early preterm birth by 42%, reduced the risk of a baby less than 2,500 grams by 10%. This is convincing to me. By all means, why not get our patients back to where they should be and possibly impact preterm birth in a very safe and adequate way? These authors believe that the optimal dose of dietary DHA or a supplement need to be between 500 milligrams and 1,000 milligrams starting at 12 weeks of pregnancy. So the earlier, the better to get to these moms. So what are the next steps? This is a trial we're currently doing in the United States. It's called the ADORE trial. It is the assessment on DHA on reducing early and preterm birth. We have it at the University of Cincinnati, The Ohio State, Kansas, and we are using a unique randomization because I don't want to have my trial limit mothers too long. So in the winning group, there will be more mothers randomized to the winning group in a blinded fashion. It's called a Bayesian method of statistics, which makes me feel better. And we no longer have a placebo because I can't do that ethically anymore. So we have the standard of care, which is 200, and 1,000 milligrams. We really believe from our genetic allele study that we really need that 1,000 milligrams. We are using singleton pregnant females, which is another thing. Watch studies sometimes include multiples, which can have more preterm birth in general. We have to have them available by telephone. We have Hispanic moms, we have African American moms, we have a nice diversity of moms in our trial. We start at about 12 weeks. They get randomized in blood draw, and then they get their regular treatment throughout pregnancy. And one thing we're doing very different than a lot of trials, we're doing mothers postpartum as well as cord blood levels. And we have found, similar to the other trials, we are finding in our population of very nice racial diversity, we are seeing significant postpartum and cord changes like the initial trials, up to 7%, which is fantastic. And we're seeing a huge impact on preterm birth. We have over 950 moms in our trial, and I hope next time I can give you an update on it. It won't be concluded until next year, but we're seeing similar great results on this. So in summary, preterm birth is definitely correlated with DHA intake and status. Maternal dietary intake is low. Not all omega-3s are DHA, so please keep your eye on that in your clinical practice. Look for DHA-specific targeted supplementation, and I think with our trial, we'll be able to give you an update on how it's related to mom's FAT-S2 status. For instance, to be more personalized, should we test mothers before pregnancy for their FAT-S2 status, and maybe they might need a little bit more DHA than others, as well as looking at that basal change from maternal baseline to cord. I want to acknowledge my colleagues across the United States. In Kansas, there's our large team there, Ohio State, and at the University of Cincinnati. We do use the algal source from DSM Nutritionals. It's the same source that's used in the formula industry, so it has a long history of safety and effectiveness. And I am very fortunate for the funding from the NIH. So I want to thank you so much for your time and attention. These are my 3 girls flying over the beach of Florida. And I just love this quote from Louis Pasteur: as we are so global and ethnically diverse, let us just impact science and really do the most robust science for the sake of our families we serve. So thank you very much.
Thank you very much, Dr. Christina. We still have 2 lectures to go, so if you have any questions, you can probably approach Dr. Christina later on. So
Yes, I'll be here today and tomorrow, so I'd be glad to have a little wine chat with you maybe.
you have a very nice picture.